We're open this hearing of the Senate Rural and Regional Affairs and Transport References Committee inquiry into regional Medicare access and funding. I'm the acting chair, Senator Richard Colbeck. I'm joined by Senator Josh DeLega, Senator Ross Cadell and Senator Jordan Steeljohn are joining us remotely. Welcome all. These are public proceedings being recorded and live video streamed via the Parliament's website, and a Hansard transcript is being made. Some senators and witnesses will participate via video conference today. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such an action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I also remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. Finally, I remind committee members and witnesses who are appearing via video conference and who are not speaking to mute their microphones, and remember to unmute when you speak. I now welcome Dr. Lachlan McKeeman from the Border Medical Association, and joining us via video conference Ms. Olivia Clayton and Dr. Laura Carter from Collected Minds, and clinical psychologist Mrs. Rebecca Gilchrist. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, I'd ask you to state your names and the capacity in which you appear today, and I'll start along the table with those on video conference. That way we can test the system as well. Mrs. Gilchrist.
Good afternoon. I'm Rebecca Gilchrist. Legal name is Rebecca Taylor. I'm a clinical psychologist coming to you from New England in New South Wales.
Thank you. Ms. Clayton.
Hello, my name's Olivia Clayton. I'm a clinical psychologist and director of...
We missed the last piece of that.
Can you hear me now?
Yes.
My name's Olivia Clayton. I am a clinical psychologist, director of... I might refresh my browser because I'm getting echo.
The sound's not coming too well through here either. Dr. Carter.
Good afternoon. My name's Dr. Laura Carter. I'm coming from Mansfield, Victoria as a rural generalist, and I work with Collected Minds also as part of my role.
Dr. McKeeman.
Yes, so I'm Dr. Lachlan McKeeman. I'm a GP in Wodonga, but I'm also here as a representative for the Secretary of the Border Medical Association.
Thank you. Now I'm going to ask each of you to make a short opening statement, and at the conclusion of those remarks we'll go to committee members to ask questions. So I might go back to Mrs. Gilchrist, or is it Taylor?
Sorry, I practice under Rebecca Gilchrist.
Yes, okay.
So thank you for the opportunity to speak today. As I said, my name is Rebecca Taylor, but I practice under Rebecca Gilchrist. I am a clinical psychologist and director of RG Psychology here in New England, New South Wales. I am a fellow of the APS College of Clinical Psychologists, and I also chair my local New South Wales Farmers branch here in Armidale. Through both my clinical work and my community work, I support quite a number of individuals across our community and nationally. So I support 25 to 28 individuals for one-on-one therapy every week. I also have 80 members of our local New South Wales Farmers branch, and I also provide supervision to a national charity, Motherland, supporting women with mothers groups via telehealth nationally. What I see consistently across both my clinical practice, consulting and community engagements is that the access to care for rural Australia is not just limited, it is structurally constrained. Recent Medicare changes introduced in November 2025 rightfully highlight the importance of continuity of care. However, there's no continuity of care when care cannot be accessed. These changes assume that patients can access a regular GP and maintain ongoing relationships required for the My Medicare registration. That assumption does not reflect the reality in many rural communities. In many rural and remote communities that I speak to quite regularly, people often rely on rotating workforces of locum GPs, or they have no local GP at all. Travel distances are quite significant, wait times are really long, and the continuity of care is difficult to establish from the beginning. In this context, telehealth is not just a convenience, it's often the only viable pathway to primary and timely appropriate care. However, the current policy settings mean that without accessing the My Medicare registered practices that we do require, patients cannot get a mental health treatment plan. And without that plan, they cannot access a Medicare rebate, which is quite substantial. To give you a bit of a context around that, the APS, the Australian Psych Society National Schedule for suggested fees for the 25-26 year recommends a fee for psychologists of 318 Australian dollars for a standard consultation. My standard rate, however, is $250, and as a clinical psychologist with an eligible referral, this may attract a rebate through the Better Access to Mental Health initiative of $145.25, which is a significant saving on that rate. What this means in practice is that people who are already disadvantaged geographically are being excluded from care due to administrative requirements and not clinical ones. The consequences are quite significant. I see delays in treatment, disengagement from care, and escalations in mental health conditions to the point of crisis, including avoidable emergency department presentations. It's not an isolated issue though. It is consistently reported by patients, clinicians, and rural communities. It reflects a systematic misalignment between the policy design and the rural reality that we live in. My submission recommends that the Medicare policy be adapted to reflect the rural conditions, including recognising telehealth as a primary mode of care, allowing flexibility in how continuity of care is defined, and ensuring that all future reforms are subjected to a rural stress test before implementation. Without these changes, current setting risks deepening inequities and worsening outcomes for an already underserved population. Thank you.
Ms. Clayton.
Thank you, Senator. Thank you for the opportunity to appear today, and patience while I refreshed my browser. So my name's Olivia Clayton. I'm a clinical psychologist and director of Collected Minds, an online psychology practice which provides support to people living in rural and remote areas throughout Australia. We're based predominantly in Mansfield in Victoria, and our team includes psychologists, mental health social workers, and 2 mental health GPs who all operate via video consult to provide high quality psychological care. So I am joined today by one of our GPs, Dr. Laura Carter, and then clinical psychologist Rebecca Gilchrist and I are facing similar issues. So we're talking about one of the 1st of November 2025 Medicare changes, which creates an access barrier for people living in rural areas who want to see a psychologist. And we are also proposing 2 options for a solution to consider. Background to this is that since COVID, Medicare have allowed people to see a GP by video to obtain their mental health treatment plan and referral to see a psychologist. On 1st of November 2025, Medicare reinstated a requirement known as the Established Clinical Relationship Rule. And this rule means that a patient must have seen their GP in person at least once in the past 12 months to access GP telehealth mental health items, or the GP must work in the patient's My Medicare registered practice, which also requires in-person visits. So while we understand the intent behind this decision, particularly the need to ensure quality and continuity of care, our experience on the ground suggests that the current settings are having unintended consequences for rural patients. Every week at Collected Minds, we see people who are unable to access timely, appropriate mental health care because of these restrictions. Many live in areas where there are few or no available GPs, or where wait times for an in-person appointment can be 6 to 8 weeks or longer. For some, travel is a significant barrier, such as clients of ours who live or work on remote cattle or sheep stations. For many, there are privacy concerns in small communities where you might have professional or social connections to your local GP and prefer to access telehealth GP for your mental health care. Or you might want to access a GP with specific mental health experience or training, and that's not easily available to you locally. We are also seeing distress among our patients who have built long-standing therapeutic relationships with their GP through telehealth and who are now being required to seek care elsewhere in person. This actually disrupts continuity of care and undermines integrated team-based treatment that is working well. So importantly, the MBS Review Advisory Committee's own telehealth review appears to recognise these risks. It explicitly notes that exemptions to the established clinical relationship rule can improve access for rural populations and recommends retaining the exemption to the rule for GP telehealth mental health items. So in light of this, we recommend one of two solutions to consider. The first being that the exemption to the established clinical relationship requirement for GP telehealth mental health services be fully reinstated. In order to address the continuity of care and the quality issue, the telehealth GP should always seek permission from the patient to include their My Medicare or usual GP in correspondence. This kind of targeted rule, alongside strong Medicare oversight of the online providers whose billing patterns suggest low-value care, would preserve rural access to high-quality coordinated care. Two, if this full reinstatement is not possible, we propose a targeted rural solution, allowing a GP to do a mental health treatment plan and referral by telehealth without having seen the patient in person when the patient lives in Monash Medical Model Area 2 to 7. And again, the GP should seek the permission from the patient to update their usual GP, including them in correspondence regarding the treatment plan and referral. So thank you very much for your time, and we welcome your questions.
Okay. Dr. Carter, do you have anything to add to that?
Hi, Senator. Dr. Laura Carter from Collected Minds in Mansfield. I just wanted to add, I guess, some personal experience being passionate about looking after my patients' mental health care. I very much believe that the changes to Medicare have caused a situation where there is inequity, particularly for rural people to be able to access appropriate mental health care. I do want to reiterate what the others have said, and we believe that the quality of the mental health care provided is important to acknowledge that delivering it by telehealth does not mean that it's of less quality, and that there is continuity that we do provide to our patients via telehealth. So I agree with Olivia that I would like to have the full exemptions reinstated regarding that face-to-face clinical relationship rule. I also just wanted to say, Senator, that I believe that making these changes won't cost the system much, but will save a lot and particularly improve the physical health and mental health of the patients that we support. Thank you.
I might suggest, Dr. Carter, that you go just to sound, because it might improve what we're receiving here if you were to turn your camera off. It save on your bandwidth. Dr. McKeeman.
Thank you, Senators. I suppose I won't add too much. It's Medicare's a complex issue, and I suppose that the connection between psychology and other telehealth-based services, which are vital for general practice patients at the moment, and the coalface of general practice, is really at a crossroads. I would, instead of framing it just as one specific issue, I think it's a real pattern of an underlying disconnect between the funding model which supports the providers of the services covered by Medicare services, but then also covers the patients to receive the best possible standard of care. With the shift post-COVID, we all thought telehealth really created business opportunities for people to enhance their skills and support growth of skill sets, and obviously the introduction of services into areas where they hadn't existed before. But I think what we often don't talk about is the clinical risk that it also creates to patients, but also providers. And so I would certainly acknowledge what's been said by the three other participants today, but I'm really keen to engage in the discussion from an overall combined service model where the integration, rather than one part facilitating the other to do its job in isolation via a telehealth consult, I'm really interested in terms of the funding model which improves the connection, rather than just My Medicare Home being a statement. It actually improves the integration and connection between all service providers for the patient at the centre.
Okay. So I might just run one quick question to you all. So the thing that sits underneath of all of this is that the way that primary health delivery is structured in regional areas in particular is such that it's not possible to deliver health services in the same way that it is in a metropolitan area, basically because of issues around workforce shortage, and also the way that the workforce delivery system works, which is a rotating system or a transient system as much as anything else. Is that a reasonable assumption to take from everything that everyone's said so far today? I'll start with you, Dr. McKeeman.
Yeah, I certainly believe. I believe the lack of consistency. So here we're a modified Monash Model 2, so considered a large regional centre. But because of the lack of workforce around our area, our local hospital service is a catchment of over 300,000 people. A lot of those 300,000 people also travel in here from modified Monash Model 3 and above, because they don't have GP services anywhere closer to them. Be they come for obstetric services, psychology, general practice, surgical. Yeah, absolutely. It operates in a different model, like you're saying, because there is not the service availability out there in the further regions. But then also when you're in a larger centre, there's also an oversubscription pattern becoming apparent because of the general lack of GP workforce.
Okay. Mrs. Gilchrist?
I absolutely agree. In Armidale itself, one of the main concerns that's been raised to table in the upcoming New South Wales Farmers Conference in July has been the lack of access to GPs. We are a large regional centre as well, not quite as large as Albury Wodonga. However, we do have quite a large population and we still don't have the GP services to service that area. We do have people coming, myself as well, to see me in Urella. Some people are driving from Scone, which is about 2.5, 3 hours drive just for a psychology appointment. So it gives you an idea of the lack of access to those services if they are required.
Ms. Clayton?
Thank you. I would agree as well. Workforce shortages are a primary concern, wait times, also lack of mental health expertise in some areas. And then particularly I would reiterate what I said before around privacy concerns in small communities where people have social or professional connections to their local GP and don't want to talk about mental health with someone that they'll also see down the footy field or at the local IGA.
Dr. Carter?
From a GP's perspective, I would like to say that it is a hard job and a lot of the time it's undervalued and GPs are totally stretched. So when there are less on the ground, it means there's more put on you to be able to deliver a service. And having witnessed, some of my colleagues, trying to deal with physical issues and mental health issues all in the space of one consult, you can see that it's not always about quality care, just turning up and seeing a GP face-to-face. From the perspective of telehealth, we do believe that focusing in and giving the appropriate time allocation to someone's mental health is able to deliver quality care.
So off the back of that, and acknowledging the point that was made in relation to ensuring quality and integrity of service for the people that are seeking treatment, looking at the implementation of the change or the removal of the exemption, that appears to me to be seeking to ensure that integrity of service, but what's manifesting because of the structure of health service delivery in regional Australia, it's actually leading to an exclusion from service.
Unintended consequence.
Yeah. So in that context, how do you, I think everyone's recommending changing the way the system is delivered with respect to, well, one recommendation, MMM2 to 7. How do you ensure the integrity of service delivery, given that that's clearly one of the objectives of the change that was made? And we saw a lot of change through that COVID period of time, and Dr. McKeeman, you talked about the fact that some people would see potentially a business opportunity to deliver services. Is it reasonable to suggest that there has been an enhancement in service delivery because of the COVID era changes, so it's made it more accessible to more people? And how do we balance out the competing interests as a part of that process? I'll start with you again, Dr. McKeeman.
Yeah, absolutely. So we don't have neurology, we don't have rheumatology, endocrinology. There's lots of services. We have very minimal psychiatric cover here with availability. We have an overstretched public psychiatric service. So the option for telehealth services has bridged a huge gap in service delivery, enormous. And it's utilised for multiple patients every single day in my practice alone, being one of the larger general practices, but I know that my GP colleagues all experience the same. It is difficult, and it comes down to, the nitty-gritty sort of whether there's terms and conditions. There may be access to a telehealth rebate and then a mandatory follow-up with a GP face-to-face within 3 months afterwards, to ensure that sort of continuity of care and centralisation of a service with someone that can provide overall standard of care, because we're talking about psychological treatments and psychiatric treatments. If there's medication in there as well. There's obvious metabolic impacts on the patient as well. It's not a perfect system, but I think that we operate at far lower than an MM2, far lower. And there's certainly lots of gaps in patient care because of these changes, because purely of the modified Monash-Mal scale.
Okay. Mrs. Gilchrist.
Yes, thank you. I think that there is a definite reliance on other service providers via telehealth that has come about as a result of COVID, which has been fabulous. This is something that I see across the board. I treat a lot of women with complex medical conditions that do often lend themselves to poorer mental health and wellbeing, endometriosis or fertility challenges, trauma, birth trauma that we've seen recently, I guess, in the media. And I think it's important that we recognise that we don't have those other medical services locally. So being able to refer, but also having the faith in our training as psychologists. We are trained primarily in a biopsychosocial model. So that three-legged stool requires that we lean on the GPs or the medical services to look into those biological factors. And I myself, in the first letter back to a referring GPs, will often say, if you haven't already, please consider a full health screen inclusive of blood screens and things like that, because we do know that iron deficiencies, B12, whatever else, may also heavily impact somebody's mental health that I can't adjust and I can't target in our therapy together. But it is a combined approach, and certainly requesting this in a letter that can be done by a GP remotely. Pathology can also be requested remotely when that is available to an individual, but it recognises the training that we have in the first place.
Ms. Clayton.
Thank you, Senator. So COVID enabled us to bring into mental health trained GPs onto our team and start providing what we became really proud of as a model where people could call our service wanting to see a psychologist, and then we could say, have you got a usual GP? Can you get in to see them to do your mental health treatment plan? Or no, that will take you several months. Okay, well, you could see one of our GPs, and with your permission, they could write to your usual GP and update them. So that was a real game changer for our clients, and we grew in size because of that as that, ease of access became known. In my view, the blanket now in-person requirement that's been enforced by the dropping of the exemption to the clinical relationship rule is not the most effective way to manage the risk of the low quality, high volume telehealth services that are out there and that we are all a little bit worried about, because really what has happened is that the smaller high quality providers such as ours have shut down their GP telehealth services. However, the large impersonal providers, the ones that we're really worried about, are often able to adapt their processes to continue operating within the rules, and some are actually flouting the rules altogether. So the policy is missing its target. And I think a more effective approach would be to combine a targeted rule for GPs doing mental health treatment plan via telehealth with the strong Medicare oversight of providers whose billing patterns suggest low value, inappropriate care. So we think the rule should not be that you must have seen the GP in person to do telehealth. The rule should be that the telehealth GP needs to request a patient's permission to CC in the usual GP or My Medicare GP into correspondence. This is what high quality online services do already, and that's what supports continuity of care without compromising access.
Okay, Dr. Carter.
Thank you, Senator. Well, I do wonder why specialists are exempt from a face-to-face rule, but not general practitioners, particularly rural generalists who do work in, more rural areas. We are, deemed to be, not don't have that available to us. My comment about, certainly for the patients that I see at Collected Minds, I can speak to that. I do actually refer for pathology, and I can do that remotely. A lot of people, blood pressure and pulse rate checks can be done in the home. People can access machines for $80 and can monitor, hemodynamics that way. They can attend the local nurse to have that done. They can also attend the local pharmacy. And if I have concerns about someone needing a face-to-face review, then I will facilitate that happening in person with their GP. And I agree with Olivia that we have very strong connections and correspond with the regular GPs to keep them all on the same page. So I feel that we are able to provide high quality care and being mindful that it is via telehealth. Once you have seen someone for a long period of time, I can attest to I have very good, strong relationships with the patients that I've been seeing, and I believe in the system.
Thanks. Senator DeLuga.
Thanks very much, Chair, and thanks for everyone for coming along today. I might just start to Ms. Clayton. In relation to your submission and just getting to the background of it, you're specifically talking about the 12-month rule or the 1 in 12 rule?
That's right, yep. There used to be, with COVID, an exemption to needing to see a GP in person every 12 months in order to see them by telehealth for your mental health care, but that exemption got dropped in November. And
so under the existing rule, clinicians working in general practice can only provide MBS-related telehealth services if they have an existing and continuous relationship with their patient. Is that right? They can provide by telehealth if they've seen that patient once, at least once in the past 12 months, and Medicare consider that a continuing relationship. But of course, the bizarre thing is that you can have a well-established relationship with a telehealth mental health care GP like ours and see them multiple times throughout the year, but be required to go and see an in-person GP you may have only met once in person. And this rule was relaxed during COVID. Do you know what the rationale was for lifting the rule? To improve access. Yep. Because in metro areas, of course, we were all in lockdown. And so the rationale was let's ease up the ability for people to access a psychologist or a mental health social worker from their home, and that means seeing the GP from their home to do their mental health treatment plan. Now, in the MSAC report, there is discussion on page 33 about why it makes sense to reinstate that 12-month rule. Isn't this what the government has done? Yes, on that page 33, I think they do talk about the importance of considerations for rural and regional people in retaining the exemption to the rule, if I'm not mistaken. Yeah. What are you reading? Oh, so my reading was that there was discussion about preventing the fragmentation of care and to foster the continuity of care, which is associated with those clinical outcomes. Just keen to your thoughts on that. The government following that recommendation. We're all in line. Yeah, we're all in agreement with the importance of preventing fragmented care, the idea of patients jumping across to different GPs and then records not being shared between those practices. However, we do think that the restriction to people in rural and regional areas to access a GP overwhelms, and particularly if there was a requirement in there that required the telehealth GP to send correspondence to the My Medicare registered GP if they have one, then that prevents the fragmented care that is the concern, or does a good deal to prevent it. Great, thank you very much for that. I might just go over to Mrs. Gilchrist. So when it comes to the back, and again on these telehealth changes, you're also familiar with the recommendations from the MSAC regarding the eligibility to help prevent fragmentation of care. And would you say that this is also associated with the best clinical outcomes?
Absolutely. We can't have positive clinical outcomes if there's no care to begin with. We need them to access clinicians in a timely manner And we also need to see this continuity of access via the GP, absolutely circling it back to their primary GP as necessary. However, if they can't access their psychologist that they would normally see, we don't have that therapeutic alliance, which we know is one of the primary predictors of therapeutic change. And we have to fit within that Medicare model of 10 sessions per calendar year, which means we have to hit the ground running very quickly. So if they can access the psychologist that they feel they have a therapeutic alliance with quickly and effectively, then we can make that happen as soon as possible and hopefully see those improved clinical outcomes and avoidance of emergency presentations.
And so really you're saying that access to the GP to be able to get that appointment in a rural and regional area is the barrier here to the telehealth services?
Absolutely. Absolutely. Without, I guess, disclosing anything confidential, I've got a client this morning. I saw an email come through there in the Gulf country and have had to delay their appointment with me on Thursday again for a third week in a row. This person experiences quite significant fluctuations in mental well-being, and they can't see me this week because they simply cannot afford to pay the private rate, and they just can't get into a GP was the reason that they gave for that.
And so do you know if they have a GP locally, or it's just, or they just could not get into, they can't get in, or?
They don't have a GP locally, so they're on a remote paddle station and they can't access that. They do sometimes access a GP when travelling to visit family in northern New South Wales. However, they have not been able to access now with these changes. They're my Medicare registered GP for that referral again. They did initially come through on a referral prior to the changes in November, which was, I believe, via one of the telehealth services. But now with these changes in place, this individual has not been able to access that care. Now, this is repeated week on. I see this quite regularly where I'm having these cancellations come through, unfortunately, because they simply cannot afford to pay privately. And it's not even a question of being able to offer a bulk bill or a concession rate, which I can do, because they can't access a referral in the first place.
And when it comes to the barriers to being able to see a GP, I'm just curious as to your thoughts about some of the barriers, because obviously the government has made record investments into bulk billing over several budgets, and we're seeing more GPs being trained. So do you think that this is going to make some difference into addressing these barriers across rural and regional and remote Australia?
I don't believe it does in our rural and remote communities that are quite isolated. Even in Armidale here, my GP practice that I go to personally does not accept any new patients. They are quite a large GP practice where others are closing or our GPs are leaving once they've completed requirements for doing their time in a regional area. So now those patients are left without referral pathways, and we're really quite a large centre here in Armidale. I've seen the same in Tamworth as well. They're an even larger centre, but in smaller regional areas where there might be one GP, they simply just don't have access when they need to in a timely way.
Thank you very much for that. That's quite helpful. And I might just ask Chair one quick question to Dr. Keeman, just in relation to the local area. Yeah. I was just wondering, because we are, like, this committee travels quite around regional areas. So can you reflect for us, as a local GP, on the services that are operating in the region? Yep. Just give us a bit of a rundown as to how services are at the moment.
So I'll go back pre-COVID. We had bulk billing GP clinics. They've since closed. There are now multiple mixed billing clinics, but there are less than there used to be over COVID. So by the end of 2022, we'd lost over 700 years of GP experience due to a couple of untimely GP deaths, and also GPs relocating from the area. these were full-time GPs, long-serving, significant patient lists, but we've also seen a massive growth in population. So not only have we had a drop-off in services, a drop-off in bulk billing services, but we've also had a significant growth in demand. Here, the urgent care centres on both sides of the border, they're a stopgap. Yep, sure, they displace some of the demand on our local ED, but they service they service as at an after-hours clinic, which the local GP workforce used to run anyway, and the funding was dropped from that. Does the local GP network see that they get bang for buck from the urgent care centres locally? No, I wouldn't say so. In discussions, that there's an initial point of contact when someone needs treatment, but there's no follow-up service. It creates a paper trail back to the patient's original GP, but then there's a delay in seeing the GP for follow-up after that initial first point of contact with the urgent care centre. So it's an option, and it certainly keeps the ball rolling, but it doesn't find a safe resting spot for the ball that is the patient's problem. The problem is that, we have most of our GP registrar applications are from metropolitan centres. GP registrars come up here from metropolitan centres, and then they return to metro or out of metro centres once they're training. So they do their training up here. They come up, they do their training because it's a great place to train. You've got that old country practice. I myself run I love it. I did the old apprenticeship model under my GP. Yep. He's a good friend of mine. He was like another father figure. I like to offer that to registrars. They come up, they bring their families, or they create a young family while they're here, but then they don't stay. That's the problem. It's a revolving door. When you've got them, you love them and you look after them as well as you can to try and convince them to stay, but the number that stay is just insufficient.
And so across this greater region,
yep.
I think there were previously 19 mixed billing practices, and now that there are 29 fully bulk billed across the greater region. Do you think that's making a difference for people to be able to access care and affordable care?
It makes a difference in accessing that initial care, but it's probably rather than actually taking the load off general practice, it's probably taking the load off small rural hospitals that have closed.
Yep. And
reducing the demand on the actual regional centre hospitals like Albury and Wodonga ED. That's what it's picking the work up from. Yeah.
So we've got 7% of practices are now bulk billing across this region. Do you think that the tripling of that bulk billing incentive will entice more GPs to fully bulk bill, to be able to?
I can't speak across the greater region. I'm mainly speaking for Albury, Wodonga and the immediate surrounding towns. The general consensus is that the tripling of the bulk billing incentive, it still doesn't cover the cost of doing business. You look at last year. CPI was 3.7%, and the Medicare rebate goes up by 2.4%. We've got wages that are going up for reception staff, wages that are going up for nursing staff, electricity bills, registration, dressing costs, all of that sort of stuff. No GP the GPs are generally considered the socialists of, will take a hit to be able to provide the care. And that's a badge that you wear with honour. You love your patients to know they can rely on you to look after them. But that's not a sustainable business model.
And about GP training in the area, do you think that there's what could be done to keep GPs in the area? So you said there's quite a lot of people coming here because it's a great area. Why are they leaving, and what could be done to keep them here?
I think there's a Murray to Mountains program which gives early medical graduates, so in their first 2 years of paid vocational doctor jobs, rotations in general practice. It's an incredible recruitment tool. We've got 2 doctors that I was working with today that have both come through either that or the John Flynn program. I myself was a John Flynn program graduate. I did my time over in central South Australia, so Jamestown, so halfway between Adelaide and Broken Hill. I was going back there until I met my previous employer, who's now a good friend, and I'm still in that practice. So GPs, once they have that initial good experience, they stay. So I think, but that sort of goes off topic to the hospital model funding and integration of those junior medical cohort and early medical graduate cohort into their local GP practice system. Yeah.
Thanks.
Okay, thanks. Senator Steele-John.
Yes, thank you very much, Chair, and thank you to the witnesses for your evidence so far today. It's excellent to get your perspectives on what the situation actually is on the ground in your communities and in your professions. Can I just pick up on a particular thread? A couple of you have shared the experience that you're seeing in the community of people being concerned about their privacy in relation to seeking either general specialist care or specialist care in the context of a smaller community. What I've taken from that is before these telehealth changes came into place, people were able to address that privacy concern by seeing a healthcare professional outside of that community to manage that privacy concern. So my question is really a two-parter. One, could you tell me more about what those privacy concerns look like in practice and the potential impacts that the return of these dynamics are having right now on people, and also whether I've understood that correctly, whether that's the kind of the privacy concern you're trying to raise with us.
Thank you, Senator. I'll speak to that. I think before COVID, there were many people in small country towns who did not go to their GP to get a mental health care treatment plan when they needed to. And then COVID, along with, a number of things, created better access for people in small country towns and rural communities to get a GP mental health care plan and referral and the help that they need.
I'd like to add to that too, if I can, please.
Yes, please.
Thank you. I can't speak for my clients due to privacy and confidentiality requirements. However, I can speak to my personal experience. My GP was actually here on Friday afternoon for our Good Friday afternoon tea. She is the wife of my husband's childhood friend. So I will not always feel comfortable. She's lovely, but I will not always feel comfortable disclosing to her what I need. And after having my first baby on an ambulance plane, I did have some complex things that needed to be addressed after that, which were delayed until I could go to a metropolitan area and speak to a GP in a large group practice with, I guess, that understanding of confidentiality and privacy. It goes two ways, because I also don't want to put that reliance on her and have her also feeling as a friend what she needs to treat for me. And I don't feel like that continuity of care can necessarily be there in a rural area. However, if I can access a GP for myself to ask these questions and seek referrals, it's going to be far quicker, which means obviously better treatment outcomes, whether that's medical or psychological.
Okay, fantastic.
Can I say one more thing too?
Yes,
I think
please do.
Possibly also exemplifies the difficulty with professional and social connections is that after we were able to bring in mental health GPs onto our telehealth team, we had an increase in clients who are medical professionals themselves, nurses, doctors, who live in small country towns who don't feel comfortable speaking to other medical professionals in their town. And we have, become a bit known for supporting other health professionals with burnout prevention.
Okay. And Ms. Carter, is there anything you'd like to add there?
Yeah, thank you, Senator. I just wanted to add the importance of addressing the mental health access because I had an experience yesterday, actually, working an Easter long weekend in a local district hospital where seeing a particular patient, for a physical problem, and happened to find out that, one of the patients I'd previously seen related to him had actually committed suicide. And these tragic things are often about a 60-year-old man who cannot access mental health support because it's not very easy for rural people particularly men, to be able to ask for help, and particularly if they're vulnerable. The GPs in the town may or may not be approachable to this gentleman, and I feel like we really need to prioritise mental health care. And it's not, I know on paper, Medicare is trying to look at the whole system, but I just want to speak to the personal experience about the importance of removing all of the barriers.
Fantastic, thank you. And could I go to the witness in the room from, I think it's the Rural Doctors Network. I'm so sorry I can't see your name plate permanently there. But if I understood your evidence correctly, your organisation has a slightly different view on the question of whether these changes should be reversed or in some ways modified for rural and regional contexts. Is that correct?
I suppose it's just in the frame. It's to say that it's just reversing the changes. I think I think that's come up because of greater issues in the system of rural healthcare provision, rather than just being down to the exclusion of one Medicare item. Certainly, yes, it does. Certainly, yes, it does. Like, it does create an issue in and of itself, but I think that's an oversimplification of the actual thing, the issue that patients in certainly our area trying to access these services have.
Right. So when you say it's an oversimplification, are you saying that in your experience, the privacy concerns we've just heard about aren't as prevalent?
Yeah, they are an issue. I suppose we've got a lot going on in our health service. I'm a GP for a lot of doctors here. It's a burden you carry, but it's just something you have to manage. Certainly, we do see medical professionals travelling from over an hour and a half away to see myself. So there is a definite role for a clause in there. But again, the problem is that they're coming to us now because the GP clinic that they were seeing 45 minutes away closed.
Yes. Oh, absolutely, and I do understand that there's a bigger picture around the sustainability of practice in those communities. Absolutely. I just think from a consumer point of view, this question of privacy and comfort of accessing healthcare, particularly mental health care, jumped out to me as a potentially unintended consequence of the reimposition of this rule. Now, just so that I've got a clear sense, for those of us that we have online that have flagged these issues, is your proposal that basically the federal government kind of has to unbreak what it broke in the imposition of this rule, or is there a modified version of this, this rule that you would be proposing that we as a committee recommend?
Yes, so the first recommendation would be that we reinstate the exemption in full, and that then covers people in metro areas as well who might have mobility issues or mental health concerns that mean that they struggle to go to an in-person GP. Mm-hmm. However, happy to compromise, and of course targeting rural is what today is all about. And it's particularly important for people in rural areas to be able to access because of the GP workforce shortage, long wait times, travel distances, privacy concerns, and access to a mental health trained GP. Mm-hmm. So therefore, we're proposing that it be reinstated just for patients, not doctors, patients living in Monash medical model areas 2 to 7, with the idea to curb the growth of the online, impersonal, large GP clinics by making sure that those GP clinics have strong oversight by Medicare when they're billing and suggest low-value care,
and making sure that those GPs are including the local GP with patient's permission in correspondence.
Okay. And what's the network's view on that proposal? To put it to the witness in the room.
That's Lachlan.
Oh yes, no, like I see. No, you're fine. Senator, I think that's a very good step because it does unbreak. It does unbreak the issue, and certainly then, and you know, like the I've forgotten the name of the fellow witness. They're referring to these online, you know, corporate centres. There's been some headway made in terms of protecting patient outcomes and, you know, proper practice that's centred on good patient healthcare, such as the My Medicare. I think that registration process that does away with issues that were done with the, you know, care plan billing. That really solves that issue. You know, someone would see a different clinic for a snotty nose on a Sunday and they'd be billed with a care plan, which, you know, used to be nearly $400 for that GP when they're not their suitable GP. So certainly I think the My Medicare registration process is good, but then simply removing a telehealth item that was available and did create that nice flow does create another barrier to a patient accessing a different form of care.
Yeah, okay, that makes sense to me. Now to the issue of GP deserts and the struggle of practices to remain viable in the communities that you work within. Well, I'm a senator from WA, and we also have the same dynamics in the West as well. There's been a lot of talk about GP policy reform in the last 12 months, and a lot of movement. But just because there's colour and movement doesn't mean it's the right colour and movement, and it's having the effect that we want to see. What would your message be? And I'll take it from each of you in turn, to the federal government, or that you would like us to echo in our report to actually address the dynamics that you are seeing in terms of practice closure, viability, and burnout as well. And I'll start online with Dr. Carter.
Thank you. I would like to propose that we reinstate the full exemption to the clinical relationship requirement for GP telehealth for mental health services, and really support GPs who are providing mental health support, because it is critical to do so. And yeah, thank you.
Thank you. And Dr. Clayton?
I echo what Laura just said and what I stated earlier about the importance of the reinstatement of the exemption. And further issues I think can be discussed from the GPs on the panel in relation to the other part of your question.
Thank you. And Dr. Gilchrist?
Thank you. And I appreciate and thank you for recognising the impacts of the deserts that we currently experience in rural and regional Australia. It has quite a significant impact on both medical and mental health challenges for Australians. I fully support a reinstatement of that exemption for GP telehealth services for that mental health item.
Fantastic. And Lachlan in the room.
In terms of GP deserts, and healthcare islands, it's a systemic issue that's certainly become way more apparent since I started my involvement in GP. But I think, from reading, preparing for this, in terms of the lowest return on investment seen on a state-based study was 5.1 in New South Wales. For every $5 you put in, that was the lowest. And so in some areas of the country, they've seen a 13 times return on investment. And I think the shift towards simply increasing bulk billing rates pushes us towards a time-based system rather than one that's actually focused on patient outcomes. Which in health systems around the world, as soon as the funding model's been pushed towards a time-based system, patient outcomes have been the one thing that's continually suffered. And it does not improve. It does not improve workforce retention. It doesn't improve recruitment. And and I would say that, simply increasing access to bulk billing clinics rather than addressing what is an issue, in the Medicare rebate system entirely being behind where it needs to be. We're building a clinic. We have a decrepit old building where we are now. It was built in the early 80s here. We're looking at building a new clinic in a growth area of Barranduda, just on the southeast side of Wodonga. It's the third largest area of growth in Victoria. Since we purchased the land and since we started the planning process to building costs have risen 36%. And the Medicare rebate, which is our major form of income for a general practice mixed billing, my bulk billing percentage is upwards of 85% month on month. I've only experienced, 2.4%, that rises. So in 18 months, our building costs have gone up 36%. So, it's an investment out of love because I love my job. It's not a financially sensible return on investment. And that's the problem, because young people coming in will do it will just do it as a job, not a vocation. And regional areas require GP to be a vocation, not a job.
Absolutely. Well, look, thank you to the four of you for your evidence to us as a committee today. It's been really very useful. And I want to thank you for the work that you do to support your communities and to keep people healthy and well, and acknowledge the genuine connection and deep personal knowledge of your communities that you brought with us today. If you go away from this committee and you think, oh, I wish I would have said an additional piece of information, you do have about 2 weeks, I believe, to provide us with more additional information. But thank you very much for your time, and I'll pass back to the chair.
Thanks, Senator Stilgen. I just want to go to Dr. Carter again, who made a reference to the exemption available for specialists versus GPs. Could you just expand on that and what the driver for that differentiation is?
Thank you, Senator. I would say that, specialists can see their patients, which we as GPs refer to them, via telehealth without the requirement to see them face-to-face. Whereas, given this new rule, as a GP, you do need to see the patient face-to-face every 12 months. Why there's a discrepancy between us as GPs and every other specialty, I'm not really sure, but I guess it can appear to undermine the value that we have as GPs, and not look at the the quality of the service we're trying to provide. I may not be the best person to explain why that is the case, but certainly there is a discrepancy there.
Is that because they are the keeper of the rules? The colleges, effectively, who drive a lot of the rules that.
So it's got to do with Medicare, I'd imagine. Medicare, they can access item numbers, and there's not a requirement that they have to see the patient face to face. So, okay. And it does enable patients to avoid a trip into the city, to be able to access all sorts of specialties, which is fantastic. So, I think post-COVID, it's been invaluable, and, even with the price of fuel and, currently that people are facing, having a trip into the city could be, easily hundreds of, dollars, if not more, depending on where you are in the country. And, access for certain specialties where there is so few specialists available, that can be really important. But I guess my point to that was really just as GPs, we don't have the same rule to play by.
Okay, thanks. And just Dr. McKeeman,
yep.
You talked about the value of the My Medicare structure and process. Yep. So is it a combination of reinstating the exemption, but also ensuring the strong connection to the My Medicare process as well as a part of that, but perhaps changing the way that it interacts?
Yes. Yeah. The My Medicare process could be so much more than just a little green tick that comes up on your record keeping software. It could really create a pathway of sharing, whether there was a way to enhance it and further develop what it actually means, because we do share patients within the clinic. It is collegiate, but it means that, when I'm on leave, someone from that practice will read that patient's correspondence coming from a psychologist, coming from a specialist, much the same, and it will be actioned within our clinic. So, yeah, it could be somehow worked in that whether they saw their GP, whether they had seen someone in some form through that My Medicare process. It could be. It could create an option.
Okay, thank you. And I think we could probably go for a little while, but we'll stop it there. Can I say thank you all to you for your evidence? I'm not sure that you took any questions on notice, but if you did, or as Senator Steele-John said, you had something else that you thought you might like to deliver, if we could have that by Thursday, the 7th of May, thank you. We shall now move on to our next witness. Thank you. I now welcome Adjunct Professor Chris Helms from the Australian College of Nurse Practitioners. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you for the Hansard record. Would you please state your name and the capacity in which you appear today?
Good afternoon. My name is Chris Helms. I am the CEO of the Australian College of Nurse Practitioners.
I now invite you to make a short opening statement, and at the conclusion of that, we'll go to questions from colleagues.
Fantastic. Thank you very much. Chair and members of the committee, thank you for the opportunity to appear today on behalf of the Australian College of Nurse Practitioners. The ACNP's submission is grounded in a simple proposition. Current Medicare settings are structurally misaligned with how care is actually delivered in rural, regional, and remote Australia. Those settings are contributing to reduced access, higher out-of-pocket costs, disruption to continuity of care, and avoidable hospital use in communities that already experience higher rates of chronic disease, preventable hospitalization, and mortality, alongside persistent workforce shortages and limited access to primary care providers such as general practitioners. In many of these communities, nurse practitioners are already functioning as primary care providers. They are delivering comprehensive, continuous, and high-quality care across the lifespan. Yet Medicare policy remains predominantly GP-centric and does not adequately recognize or enable NP-led models of care or the nurse practitioner workforce. That mismatch is clearly visible in the data. Over the past decade, Medicare-subsidized nurse practitioner services have increased by more than 400%, but NP bulk billing rates have fallen from over 94% in 2015-16 to around 81% in 2024-25. At the same time, approximately 1/3 of the NP workforce is underutilized or not working in designated NP roles because of current funding and policy constraints. This is not a workforce capability problem, it is a policy design problem. The 1 November 2025 Medicare changes have made these problems worse. Our submission identifies 3 key mechanisms: financial disincentives for patients choosing an NP as their primary care provider, restrictions on telehealth continuity, and exclusion from continuity of care funding frameworks such as the My Medicare service. In practice, that means patients in rural and remote communities are facing reduced service availability, increased costs, and greater barriers to accessing care closer to home. This is particularly concerning because the evidence does not suggest NP-led care is a compromise. It shows the opposite. Our submission cites strong evidence that NP-led models are clinically effective, improve access, and deliver economic value. Independent analysis performed by KPMG found that for every $1 invested in MP models of care, the estimated return to the health system was between $1.10 and $12.40, driven by reductions in emergency department presentations, hospital admissions, and ambulance transfers. The ACMP is asking for 3 immediate priorities. First, equitable Medicare funding for health consumers who use MPs as primary care providers, including access to bulk billing incentives and rural loadings. Second, telehealth settings that support continuity of care, including removal of the 12-month face-to-face requirement for MP-delivered telehealth in rural and remote areas. And third, reform of My Medicare so MP-led practices are recognized and funded as eligible primary care providers. Ultimately, Medicare should support care based on patient need and clinical function, not provider type. If this inquiry is serious about improving rural access and reducing avoidable hospital use, then MPs must be enabled to work to full scope as part of the solution. Thank you.
Thank you. Would you like to start, Senator DeLuga?
Thank you. I've just got a couple, look, thanks very much for coming across today, Professor. I'm sure the committee does thank you, I'm sure, for the very huge submission that you've made and very detailed. Thank you very much for that. I'm just wanting to double check, and for people following along with there are over 2,000 nurse practitioners, is that right?
3,400.
3,400.
As of December 2025.
And you're probably following the workings of the Senate in relation to the current Health Services Amendment Bill. I'm wondering if you could give us some of your feedback about the how that bill would help with the broad scope of practice reforms that you've highlighted in your submission.
Can you just provide a brief overview of the bill? So I'm actually
sorry, the Health Services Amendment Bill for prescribing
PBS access?
Yeah, PBS bill. Yeah.
All right. So can you ask your question one more time, please? Sorry.
How do you think that bill will help with the increasing the scope of?
I think that ultimately, I was one of the original architects with a group of people on the Nursing and Midwifery Board of Australia to actually help design a new nursing workforce called designated RN prescribers. There were 2 key principles why we made this new registration standard and endorsement standard for DRMPs. The first was to increase access to regional and remote communities, and particularly in ACHOs, aged care facilities, particularly in communities that have poor access to a general practitioner workforce or even a broader health workforce. The second was actually to help build a future pipeline of nurse practitioners to be able to build capability within the nursing workforce, to actually build nurse practitioners into the future, particularly in primary health care. As far as that bill is concerned, I think it's critical to actually go ahead and pass that bill to actually enable PBS subsidies for designated RN prescribers because we found with nurse practitioners, for example, for the first 10 years of their existence here in Australia, the restrictions on PBS access didn't stop nurse practitioners from prescribing medicines, for example. It just shifted costs to the health consumer. This is simply avoiding that cost shifting to health consumers, which is critical, particularly when you're working for communities that may not be able to afford their health care. There might not be a bulk billing GP nearby. And we see this future workforce being augmented by the PBS access as critical for regional and remote areas.
And I think you referred in your submission was GP, like this will remove GP gatekeeping of, would you say? Or
I think, no, that's not the intent at all. I think as far as quote unquote GP gatekeeping, I hear that sort of term used in context of specialist referrals.
Okay.
This is actually going to be quite helpful for general practitioners who can actually maximize their workforce if they go through the change management process of actually enabling the workforce to actually use designated RN prescribers. This is going to be a game changer, I suspect, for medicines access. Yeah.
And in your submission, you noted the work that nurse practitioners do for First Nations communities. Can you just tell the committee some of the work that you do?
So I used to work in a remote community called Gunana up in far north Queensland. And several of my nurse practitioner colleagues work for Aboriginal community-controlled health organisations throughout Australia. As far as the MP workforce is concerned, quite frequently, particularly from my experience, there were infrequently general practitioners available. So I was the only sort of primary healthcare clinician available on the island at the time. I can speak from my experience and from the stories of my colleagues, but when I was providing primary health care on the island, I was trying to keep people out of hospital. And so one example is somebody who's receiving palliative care for metastases of her ovarian cancer. And she actually was, for lack of a better word, dropped on the island without any supports in the community. And so what that resulted in me is, because she was in chronic pain, was me getting up at 2, 4, 6 in the morning to actually give her subcutaneous pain relief as she neared death. So quite frequently when you are a nurse practitioner in those communities, you're working, quite independently. You're working to the best of your abilities. You're using your specialist colleagues quite frequently through the phone or through telehealth to actually engage with them and make sure that people are getting comprehensive care. A lot of the care that nurse practitioners provide in Aboriginal community-controlled health organizations and Aboriginal communities is really strongly focused on preventative health care. Some of the most simplest interventions that you can make as a nurse practitioner or any health practitioner is providing a box of Kleenex to a client so that they can blow their nose so you don't get as much eustachian tube dysfunction or otitis media. And the interventions can be as complex as providing a tissue box of Kleenex versus actually, actually performing an echocardiogram at the bedside for a client and evaluating whether they have, for example, symptoms of rheumatic heart disease and valvular heart disease, for example. And so the care of nurse practitioners in these communities is heavily focused on preventative health care, but it involves aspects of chronic disease management, acute management of sudden severe illness as well, and is equivalent to, but using a different lens than a general practitioner, for example.
Thank you, and again, thank you to the NP workforce for the work they do. And just finally, in the conclusion of your statement, you note that the core issue is therefore not workforce supply, but system design. Medicare policy settings must evolve the support models of care that are already operating effectively in practice. Could you expand on that statement for the committee?
Yeah. So nurse practitioners like myself, so I work in a clinical practice in Canberra. Lots of nurse practitioners are working in scenarios where they are working with marginalized populations. And as far as the care that we provide, again, when you're working in a generalist context or a primary healthcare context like I am, I'm providing the spectrum of care that you would see in general practice. I'm providing that with a nursing philosophy of care, but the outcomes with my clients are relatively the same. The problem is that when I'm providing care for a client that has a long-term health condition, let's just use depression as an example. Depression, actually, no, let's just use anxiety, generalized anxiety disorder. So I've got a client, I've developed my own sort of chronic condition management plan for that client, who's going to be involved in their care, making sure that we're getting supports around that person for their generalized anxiety disorder. Not always using a psychiatrist, because unless I can't handle them, I don't actually get a psychiatrist involved. And in a lot of clients, I will actually start them up on escitalopram, which is a drug that's quite common. It's one of the first-line drug. It's called an SSRI, that's used for the treatment of generalized anxiety disorder. However, PBS restrictions, current PBS restrictions state that if I start that medicine and I haven't gotten a psychiatry input, or if I have not performed a GP mental health care plan on that patient, which I'm ineligible to do, they actually can't receive subsidies on the costs of that medicine. And so I prescribe the medicine because that's the best thing for the patient. We try to get them into psychiatrists, but that's very difficult, as the workforce right now is quite problematic. But I guess the issue is that I'm providing long-term management for long-term health conditions for clients. And despite me getting involvement with dietitians, exercise physiologists, speech therapists, occupational therapists in a patient's care and their management journey, I, as a nurse practitioner, cannot actually formulate a GP management plan for that client, which will enable subsidies for that patient. So again, costs are shifted over to that patient instead of subsidizing their care. As far as a great example, for example, is a client that came to see me recently that had symptoms of gynecomastia from the medications that they were taking. They were taking antipsychotics. And the Commonwealth has funded a GP support line for GP and psychiatrist discussions about complex patients. I try to call that line, which is a Commonwealth-supported line, to actually get some advice about how to manage a patient's gynecomastia and their prolactin levels. And I was told that the Commonwealth is only funding GP psychiatry consultations. And so even though I'm managing this patient across the spectrum of their life, I can't actually use specialist services that are freely available to general practitioners. Likewise, with my Medicare, I, as a nurse practitioner, may be eligible to register my practice with my Medicare only if I can obtain a general practitioner to work with me. That's the ideal scenario. But the problem is that 30% of the GP workforce don't want to work with nurse practitioners, given their own survey findings from their surveys that they've put out to their members. And given the fact that we already have a GP shortage in this country, I've got Buckleys of getting a GP into my practice to actually help create a multidisciplinary care environment. So what I invariably do is create all these linkages within the community to actually provide supports for my patients. But that actually adds costs and travel and expense, particularly when you're talking about a regional and a remote perspective.
And so are you accessing that particular service that's provided by the Commonwealth would then greatly assist you to be able to assist the patient?
They will not assist me. So what I have to do then is go through the Public Health Service to actually find a referral, and that waiting period is about 6 to 12 months in where I'm from anyway.
Yep. Thank you. Look, thanks very much, and thanks for that scenario of one of your patients as well, because I think that's quite helpful for us to think about. So, and we know people in regional remote areas are quite prone to mental health, anxiety, depression disorders. So, thank you very much. That's helpful. Yep. Thanks, Chair.
Thank you, Senator Steele-John.
Thanks, Chair. Thank you for your evidence this afternoon. It's much appreciated. From your background and my knowledge of your organisation, you're very familiar with giving evidence and kind of shouting from the rooftops about some of the policy changes that are needed in this space. What is the kind of the one thing or the 1 to 3 things that you really want to drive home to us as committee members as we consider what the recommendations from this inquiry should be?
One thing that I see is the fact that the vast majority of nurse practitioner practices have, because we don't get the same incentives that general practitioners get, we don't get access to a PIP, we don't get access to a WIP, we don't actually get access to a lot of funding streams for our clients. And so we've purposefully, over the past 26 years, designed models that have extremely low overheads. A lot of us work from our homes and have taken advantage of the telehealth technology. Even before COVID, we were taking advantage of telehealth because we recognized that there was a low overhead model of care, and we could provide care through pharmacies, we could provide care through telehealth, and give our reach out to regional remote areas. And whether you're a generalist nurse practitioner like myself, or primary healthcare MP, or whether you're a specialist MP who's providing pump starts in a remote station via telehealth, the issue is that when the 1 November 2025 changes came through, nurse practitioners were purposefully excluded from the, number one, providing mental health care as an exemption for their clients. And so all the mental health nurse practitioners suddenly had to shift their costs to patients because they were trying to bulk bill those patients in the past, or at least provide them with subsidies. So right now we have a large mental health MP workforce that have been providing outreach services that can continue to do so, but it's just shifting costs to health consumers and making access more difficult, particularly when they're in a vulnerable state with severe depression or anxiety. So from my perspective, we need to reconsider the fact that nurse practitioners were, quote unquote, put on a level playing field with general practitioners with respects to the telehealth exemptions, and recognize that we don't have any of the funding streams that general practitioners or general practices have. And so what I would ask the committee is that, number one, we enable an exemption for nurse practitioners who are working in metropolitan areas, providing outreach services to rural and remote areas, but also for those nurse practitioners that are in rural and remote areas providing telehealth services, that they also have exemptions to providing telehealth services that are that don't require the 1 in 12 face-to-face rule. I think that's probably the most important thing that I can see, because it affects a wide range of specialists and journalists within the nurse practitioner workforce nationally. I think the second thing is the recognition that right now I can't get a general practitioner to work in my clinic, and I have about 1,800 active patients on my books right now. Most of them are trans and gender diverse, which allows for an exemption through telehealth, for example, and they live in regional and remote areas. But the problem is that sorry, I just lost my train of thought. ADHD. As far as the provision of these services, I can't actually get a general practitioner to work for me. And whenever I look at my patients that are on my books, I've got 1,800 patients that are active in the last 2 years. Not one of them are registered with my Medicare. Not one of them. And I desperately want to register them with my Medicare practice as my Medicare practice, but unless I have engaged a GP, I can't do so. So I guess from my perspective, there needs to be a really good look at my Medicare and whether we can actually enable it for nurse practitioner clinics that are registered under the Australian Commission on Safety and Quality in Healthcare as a primary care clinic. I also think that we strongly need to be looking at enabling multidisciplinary care by allowing nurse practitioners to have mirror items to general practitioners for the management of long-term health conditions, and such as mental health conditions and physical conditions as well, so that we can actually enable multidisciplinary care by providing allied health referrals through those condition management plans like the general practitioners do. That's probably the two biggest asks is, number one, align the exemptions that nurse practitioners, that general practitioners have with nurse practitioners, add in a rural and remote exemption for telehealth services, and create mirror items for chronic condition management plans and mental health care plans so that nurse practitioners can be recognized as primary health care providers and actually enable multidisciplinary care. The third ask is really a very, very big look at subsidies for diagnostic imaging for nurse practitioners. Since 2010, nurse practitioners have been able to order any pathology exam that's required by their patient to manage their condition. That's not the issue. It's worked outside the box. What hasn't worked is diagnostic imaging. Right now, nurse practitioners can only order a very limited set of ultrasounds and plain film imaging. We can't and also a low-dose CT scan for the National Lung Cancer Screening Program. We simply don't have access to diagnostic imaging items that we desperately need to manage our patients, like MRIs, like the GPs have, like CT scans, like ultrasounds of the thyroid. I can order an ultrasound of the abdomen, but I can't order an ultrasound of the thyroid when I'm managing somebody's hypothyroidism or hyperthyroidism. It just doesn't make sense. If you can get those three things, and if you can get those three things to work, the rest can be sorted out. But those are critical.
Okay, thank you very much. That's a great summary, and it's kind of covered the other questions that I had. So I'll leave it there, Chair. Thank you very much for your evidence today. And if you kind of step away, as I said to the previous witness, and go, oh, I should have mentioned this other thing, you've got about 2 weeks to provide it to us. So thank you very much.
Thank you very much.
Thanks, John. So the registration of your clients, your patient list with My Medicare, is it that the system doesn't provide for that without a GP in your practice?
That's correct. So you can be a general practice. You can also be an Aboriginal community-controlled health organization, or you can be a nurse practitioner-led clinic, but only if you've engaged a GP. And that's very difficult when 30% of the workforce don't
30% don't want to work
Yep.
with an NP. Is that anywhere up and down the supply chain? So the requirements for engagement of a nurse practitioner with a GP in a patient's care becomes a limiting factor. That whole process, regardless of what the professional or business relationship is between the GP and the nurse practitioner.
Yeah, it's actually quite fascinating. So over the last 6 months, the ACMP has received submissions from 3 general practices, all located, actually 2 of them located in regional areas, that have said that they have to completely reconfigure their desire to have a nurse practitioner in their general practice because the rebate amount through the bulk billing incentive program is substantially greater for a general practitioner than it is for a nurse practitioner. So a nurse practitioner is not eligible for bulk billing incentives, which means that, about a year ago, our rebates increased by 30%. Actually, so I should say patient rebates have increased by 30%. That kind of narrowed the gap between what a bulk billing GP would get versus a nurse practitioner would get, or the practice would get, or the patient would get. When the triple bulk billing incentive program came along and some of the incentives with My Medicare came along, the gap widened between the nurse practitioner workforce and the general practitioner workforce.
Reopened.
And it re-exacerbated a problem. So the fact that we don't have bulk billing incentives means that although you have some GPs out there that are brilliant, that actually love this idea of bringing a nurse practitioner in their practice, they're actually saying, listen, it's actually really expensive to hire you because I'm not getting what I need from you for that room rental, for that room in the general practice. And so they're actually thinking, let's reconsider the nurse practitioner workforce because we're not getting the rebates.
So as much as it might be a philosophical thing, it's also a business model thing.
It is
because
definitely.
It doesn't generate a return.
It doesn't.
We heard a previous witness talking about building costs going up by 30% since they purchased the land that they were looking to develop. They have to get a return on that infrastructure development as part of their overall business costs.
That's exactly right.
And the current state of play with respect to nurse practitioners doesn't assist with that in any way because of the differentials in the rebates.
That's exactly right. The differentials in rebates would be improved if you would allow nurse practitioners to have access to bulk billing incentives for their patients. The infrastructure is a major consideration in regional and remote areas. The cost of upkeep of the building, actually getting housing to house persons as they go out to the community, actually, if they're a FIFO, for example, not an ideal model, but that's the current state that we're in right now, where we can't even get housing for people if they even want to work in a regional community, at least part-time.
So in terms of accessibility into regional area, where, in your experience working on an island in an Indigenous community, you're it, effectively, or you're the top of the local tree, if you like.
The primary healthcare tree, yeah. Yep.
To the top of the local primary healthcare tree with other systems of support that sits around that. The lack of access to these measures actually then limits capacity for delivery of the whole system as such. I mean, I'm a big fan of the work the government's doing in terms of expanding nurse practitioner scope of practice. I think that's a really good thing. But the way that the system then works actually inhibits the capacity to do what's being proposed with the reforms to the scope of practice side of things, because it doesn't pay the bills.
Nope. And if I had my preferences, I would actually have a combined. I actually think that one of the solutions for particularly regional remote areas is block fund, like doing a mix of fee for service, which is what we're currently using right now, but also doing block funding for that service, using a hybrid model where you're reimbursing on outcomes. So if you can get, like, for example, 80% of your clients with diabetes type 2, if you can get 80% of your clients with the HbA1c less than 8, for example, you get a sort of, based on a SWAPI, for example, an incentive for that practice to help build it. That actually helps promote multidisciplinary teams. And I think that we need to be moving away, particularly in regional remote areas, from this idea of fee-for-service. It's not enough to actually make it work. I think that you have to use both fee-for-service and block funding in those models and look at market gaps and say, right, so we know that this area has a problem with primary healthcare access. Let's do some additional grant funding for a nurse practitioner-led clinic or, a multidisciplinary clinic, and provide block funding to actually help build that infrastructure so that you have a purpose-built facility that wraps around the community, essentially. Did I answer your question, Senator?
Yeah, it sends a few bells off that relate to conversations I've had previously. So in terms of the 1 November 25 changes, which restrict access without that annual face-to-face, would you see that as effectively being a step backwards in service delivery, particularly as it applies to regional areas around the country?
Absolutely. And to my knowledge, it wasn't really stress tested as far as the impact. There was no modeling that I saw about the impact that these changes would actually have on regional remote communities. And that's not just for nurse practitioners, that's for general practitioners as well.
We spoke with previous witness in relation to the way that the My Medicare process works in the assurance of quality of delivery of service, and the way that interacts with the approval process or otherwise for remote access to service. Do you see a way that might be made to work?
Yes. So I can speak only from what I envision for nurse practitioner-led clinics in regional remote areas. There is, for example, a clinic based up in the Northern Territory that is an MP-led clinic that provides general practice services or equivalent services. The problem is that when it comes to getting your practice accredited, which opens up funding mechanisms to help support general practice and primary healthcare, there's currently widely accepted RSAGP accreditation standards, which are used for general practices. There are no such standards per se for nurse practitioner-led clinics, except for the Australian Commission on Safety and Quality Healthcare primary care clinical standards. The problem with that is that those standards, to get accredited against those standards, and I'm actually ready to go with my practice. I have all the policies, the frameworks, all the data that you need to get accredited. But it costs between $8,000 and $10,000 just to get accredited. The problem with that is that, general practices will frequently receive incentives to actually help pay for the cost of accreditation. Nurse practitioner-led clinics don't get any incentives. There is no incentive for becoming accredited with the primary care standards. So in one respect, I know in my heart and all the other nurse practitioners I know are providing excellent care that's safe, that is actually making sure that we're providing outcomes that are important for communities and for individuals. But there's literally no carrot to spend $8,000 to $10,000 on accreditation to provide that reassurance to the department that we're providing care that is on par with a general practice, for example. Was that, or did I answer your question, or should I?
Yeah, look, I mean, you have, and then you've gone off into
A tangent,
creating no, I wouldn't say tangent. It goes back to the systemic
issues
that we're talking about with respect to system design as much as anything else. But how we actually achieve the objective, which is the stated objective of expanding scope of practice, if the business model doesn't support it, it's effectively creating a local
bottleneck.
A local market failure mechanism, because the local market, under the structures that exist, don't support a business model.
Yep. And you'll see that not just with general practices, you see that with urgent care clinics as well, where you have a scope of practice review, you've got the nurse practitioner workforce plan, but these urgent care clinics that are providing services, again, that bottleneck that they encounter is, at the end result is, you can have a nurse practitioner, suturing up a 7 centimeter wound and get $35 for through a Medicare rebate for doing that, versus, I don't know, maybe $280, $160 through a Medicare rebate for general practitioner services. And so you're seeing these sort of funding mechanisms actually impacting upon scope of practice at the local level, as you say. And until you fix those funding mechanisms and look at Medicare not as, or the MBS and PBS as primarily medical practitioners and general practitioners, as a enabler for the whole workforce, and until you fix that, you're going to encounter those bottlenecks unless you do what I do, which is privately charge and patients get a rebate for my services. I don't want to privately charge. I want to bulk bill, but I can't because it's just not sustainable.
So the concept of the Medicare card, not the credit card, really falls away because of the structure of that process.
Yes.
Okay. Thank you for your evidence today. If there's anything that you've taken on notice, I'd ask you to get it back to us by the 7th of May. We'll now break for a short period of time and return at 3:30. Thanks, colleagues. Ask Jackie. She is there. Terrific. Thank you. I now welcome Ms. Mark Nicol, representing the Women's Centre for Health and Wellbeing, Albury Wodonga, and via video conference, Ms. Jackie McMillan from Women's Health New South Wales. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, will you please state your names and the capacity in which you appear today? We'll start with you, Ms. Nicol.
So I'm Marge Nicol, General Manager of the Women's Centre for Health and Wellbeing in Albury Wodonga.
Ms. McMillan.
My name's Jackie McMillan and I'm a Senior Project Officer at Women's Health New South Wales.
Okay, Marge, we might go to you first, and if you'd like to make an opening statement, and we'll come to you shortly, Jackie.
Okay, so I thank you, Chair and committee members, for welcoming me here today. You already know my name. I'm the General Manager of the Women's Centre for Health and Wellbeing in Albury Wodonga, and locally we're known as the Women's Centre. So I'm appearing here with Jackie, who we've worked closely with as a part of our peak body, and I'm not just here as a service provider, I'm also here as a voice of women in our community who can't be here, don't feel their voices are heard, and are too stressed, too exhausted, or too invisible to advocate for themselves. The Women's Centre is a local cross-border service, not-for-profit organisation serving women and girls from both Albury Wodonga and further abroad in our region. We're not a clinical health service, but we are a place where women come to when the health centres or the health system fails them, turns them away, or places them on long wait lists too long to matter. Then they come and say to us, what do we do? Where do we go? I need help. We're an early intervention service, and we are a service that people come to us when they're in crisis, particularly family and domestic violence and sexual assault victim survivors. And we are, frankly, a pressure valve for the Medicare system that is struggling to meet the needs of the most vulnerable. Thanks to the core funding increase from the New South Wales Government at the last elections, we've been able to meaningfully expand our counselling, our intake, our referral and case management capacity to hold the women that need it. And our figures show that we've increased our occasions of service by 255% in this time, and the women that we work with by 108%. And we have no time limit on how long we work with these women. It's directed by their needs and their wants and how long they want to work with us. So if they have a mental health care plan, that doesn't matter to us. We just work with them. It could be year after year or one off, one on, whatever they like. But we're trauma-informed, we're safe, we're client-centred, and we're women's only safe place. And this is where I sort of want to stress to the committee that we can't do this alone as a service provider, and we shouldn't have to. We do not have the funding to employ a nurse or a nurse practitioner or a GP, but the need is there for us to do that, but we do not have the funding. We have the space for it, but we don't have the funding, which is really sadly lacking. So, and it's the cost that is prohibitive for us to do that without extra funding. So when our clients need medical care, we refer them on and out to the GPs or wherever they need to go. And time and again, we watch the referrals go nowhere. Why do they go nowhere? Because they can't afford it. The barriers are the barriers are not small inconveniences, they are systemic. Women are encountering bulk billing GP wait lists that stress weeks or months. For women from culturally and linguistically diverse backgrounds, the absence of multilingual GPs is not a minor inconvenience, it's a wall, it's a stumbling block. And so many of these women make a rational, if devastating calculation, the health system is not for them. And they've told me that personally in a bowel cancer study that we did recently with them. We just don't go, they say. It's too hard. Apart from not understanding the system, it's just too hard. They disengage, they go without, their health deteriorates quietly, invisibly, at significant cost, personal, social and ultimately economical. This is the inequity I'm asking the committee to confront. In Albury Wodonga, where we live, it's a regional community that, for all its strengths, it's not Sydney and it's not Melbourne. The tyranny of distance is real. Travelling to the metropolitan centres for specialist care is not a minor inconvenience for the women we serve, it's simply impossible. Limited local choice combined with the cost and the complexity of accessing Medicare services means that geography compounds disadvantage. Women in regional areas are not receiving equivalent care to access to care, and the Medicare system as currently structured does not account for this. Things that I'd like you as a committee to consider with in regards to the Medicare framework is properly funds and insensitivises bulk billing in regional and cross-border communities, removes the arbitrary 10 or 20-minute appointments constraint that forces GPs to choose between thoroughness and throughput. And I've been there when they've said, it's 10 minutes now, I can't do the next thing and the next thing and the next thing. So then you've got to come back, and then you've got a long wait list to get back in to see that GP. Consider having only out-of-pocket, if any, payable at the time of service to the provider, rather than having the entire cost paid and then having to wait for the Medicare refund. Recognise and support multilingual and culturally safe general practice, and acknowledge the critical role that community-based not-for-profit services play in early intervention and fund them accordingly. Every woman who cannot access affordable, timely, respectful healthcare is a woman whose potential contribution to her family and community is diminished. This is not just a personal tragedy, it's a policy failure. We need a Medicare system that is generally fair, not in principle, but in practice. One where a woman in Albury Wodonga has the same access to dignified, adequate healthcare as a woman in any capital city. Not because it's aspirational, but because it's right. And I thank you all for supporting us in making a difference and for listening to my little spiel.
Thanks, Marge. Jackie? I'm being very familiar. I'm sorry about that.
No, please. My name's Jackie McMillan, and I work at the Women's Health New South Wales, which is the peak body for 21 non-government women's health centres and special purpose services operating in New South Wales. We really appreciate the opportunity to appear here today before the committee, alongside our member Marge Nicol, who's made a great case for the women of Albury. The women's health sector plays an important role in health equity. This was recognised recently, as Marge told you, by the New South Wales Government with a $34.3 million core funding increase spread across 4 years in the 2023-24 state budget. The increase to core funding recognised the essential nature of community-based healthcare and the domestic violence support that our members provide to women and children. When core funding doesn't keep pace with the demand upon our services, more pressure is placed on the public health hospital system. The New South Wales Minister for Women, the Honourable Jodie Harrison, put it like this: women's health centres are vital in providing a safe place for women who might otherwise fall through the cracks, and are critical in removing barriers to healthcare by providing women the care they need in their own communities. So in the last financial year, the core funding increase enabled our members to provide more than 114,000 occasions of service to women, incorporating more than 223,000 presenting health issues. And 59% of our clients were in rural, regional or remote locations. So women's health centres exist to get women the healthcare they need when and where they need it. But we don't do that work in isolation, as Marge told you. Around each of our centres, there's a network of health and allied health services, including GPs, that our members establish and maintain to ensure that women get a good connection to the mainstream health system. Sometimes we're lucky enough to be able to bring those GPs in-house, and where we can resource them with the time they need to address women's complex and intersecting health issues. Other times we need to rely upon external services, and particularly warm referrals to GPs who we know can provide culturally sensitive and trauma-informed care. We need a Medicare system that encourages and rewards GPs for delivering that complex, time-consuming, multidisciplinary care that our women need where they need it. So Women's Health and our members contributed to this inquiry because we see the women that we see sit at the pointy end of health inequity in Australia. Most of the women accessing our services experience greater barriers to optimum health than your average Australian. Our statewide remit has shown us that these barriers are even more pronounced in rural, regional and remote locations. In our submission, we also drew attention to inequities in particular healthcare services, including sexual and reproductive health and mental health, where regional, rural and remote workforce shortages are deeply affecting the health and well-being of the women we see. We really thank you for your time and the work that you'll do in narrowing these gaps in health equity.
Thank you, Jackie. Senator De Luca.
Thanks very much, and thank you for your attendance today and for your submissions. I might ask you, Ms. McMillan, about the about your New South Wales lens. Obviously, the federal government has invested quite a lot in Australia's first endo and pelvic pain clinics across all states and territories. In New South Wales, what are you hearing about those clinics, and are they making much of a difference? And I appreciate, Ms. Nicol, there's one in Wagga, but not here. But yeah.
Before Jackie goes on to that, sorry, Jackie, are you aware that where we sit in Albury-Wodonga Health, we don't really sit in any state, so that's why some of the stuff that is put in a state doesn't come here. So we're disadvantaged at that as well, locally. Sorry, Jackie, go on.
So two of our members were lucky enough to receive funding. So Coffs Harbour Women's Health Centre, who already provide a pain clinic and endometriosis services. And opening just next week, Central Coast Community Women's Health Centre is another of the funding recipients. So we're yet to see what that work does in Central Coast, but we're very excited about it and very appreciative. However, as a peak body, we do field inquiries from all over the state, and I did have I did speak to a woman from Armidale, and when I looked up what was closest to her that was bulk billing, it was Coffs Harbour, and that's a very long way for her to travel. And I felt really that was a very difficult conversation to provide that to that woman, that's her closest service.
And with the increased bulk billing incentives across general practice, are you seeing more women being able to see a GP because of the increased bulk billing?
It wasn't what they reported to us when we were making this submission. There were still quite strong problems with bulk billing. I think it was Wagga that told us that they only had, I think it was 8 practices of 21 in the area that were offering bulk billing, and all of our members reported very long time waits in those practices, or GPs closing their books to new clients, which made referrals very difficult for us. We haven't seen a big change about that, but we have heard some positive things about the urgent care clinics.
Also UCCs, but also across general practice, are you seeing more women being able to take up the option to attend, or are you saying because of the bulk billing and the practices that do have transitioned to a full Medicare BB clinic, that that people can't get into them now because they've closed the books because the demand was so high?
Yes, demand is outstripping services.
Would you encourage other GPs to get on board to take on and become a bulk billing clinic?
Absolutely. We need more bulk billing GPs, and I think that you'll see the benefits in what we spend on healthcare in the long term if people are able and feel confident visiting the GP more often at the beginning of a problem rather than down the track when they don't have any other choices.
And when it comes to the going back 2023, there was a new level E item for consultations of 60 minutes. Are you hearing anything from across your membership as to whether or not this is helping women, or what would you recommend about that new or relatively new?
We were delivering a project on strangulation and sexual choking, so we actually advertised to all of the doctors that we trained for that project about the consultation level E, because we were so excited because it was the first one that really gave a GP time to sort of look at the referrals they needed to provide so that they're taking a holistic look at health. We did have a little bit of pushback by saying those consultations still tend to take up more time than the allotted time, and you can actually make more money from Medicare by doing a number of short appointments. So yes, we were excited by the change. Yes, we've been pushing it as a way, particularly when a woman's experiencing domestic and family violence, And we've been asking women when they've, for example, if they've experienced strangulation, to ask the GP to book a consultation level E, but we're still seeing some hiccups in the rollout, and limited numbers of GPs are talking about doing those types of appointments.
And thanks. We noticed that your additional submission, as well as Ms. Nicol, about the case study about sexual strangulation and assault, and it was really quite a challenging read. As to and the adverse health effects that women and people suffer as a result of this. What's your advice for the committee on how we can encourage women to come forward? Because obviously your case study involved a nurse who was in the system, and there was quite a bit of stigma. What do you suggest to the committee that we can consider?
It's a tough one. When we rolled this project out, we found in every area we needed to come up with a different solution. So, for example, a shout out to Campbelltown Hospital. They allowed us to send women up to 9 months after the initial strangulation event, because their imaging is free. So if a woman was experiencing neurological symptoms, she could attend her ED, even if the event was 3 months or up to 9 months earlier. And that allowed her access to care, because one of the gaps we found is that if we send a woman to a GP to manage, and a GP is, the person who should be managing primary care for her, if he sends her to get scans and there's no bulk billing option available, she just won't go, and she may be lost to care entirely. And you can see from Marge's case study, that's pretty devastating when a stroke was one of the injuries that could come from this. So I guess in another area, up on the Northern Rivers, Women's Health Northern Rivers found that there were no services in their local area that could respond to do a neurological assessment of a woman who'd experienced strangulation. So they actually had to apply for a grant to get services to come to their centre, and they solved the issue that way. So I guess, to me, making neurological services cheaper and more accessible. I think it's about $3,500 to have an assessment to work out whether you have a brain injury from strangulation, and it's a long assessment. So I think you're looking at ways to solve this across the board rather than localised fixes, to make sure that we have access everywhere, and particularly bulk billings on scanning.
And being just a couple of blokes in the room here today that are asking you guys questions about this, can you? I'm so sorry if I don't know the answer, but is the NFS is this increasing? Are you hearing that there's more of this occurring in the community? Is this increasing or?
Perhaps the thing that's increasing is sexual choking among young people. So we have some Australian research led by Professor Heather Douglas from University of Melbourne, and they found 57% of young people have engaged in sexual choking. So that's strangulation with consent in a sexual context. So we're going to see more injuries, and if people are engaging without understanding that strangulation can lead to a brain injury. So it is a significant health issue. And often when women also have experiences of trauma, so say the strangulation has occurred in the context of domestic and family violence, you're going to see overlap between symptoms of complex trauma and strangulation, so often, and a brain injury. So you might not recognise the brain injury. So one of the things that we did was we trained service providers to look for a mechanism of injury. Has the woman been strangled? Has she had a hit to the head? If so, and she's experiencing neurological symptoms, we created a referral letter that you can hand to a GP. So the service provider fills out the referral letter, gives it to the woman, she takes it to the GP, and it tells the GP exactly what we'd like investigated. She's experiencing these symptoms, she was strangled this long ago, and she still has headaches, she's still having trouble sleeping. Can you please look at these things for her?
Thanks very much for that. I might just pass the call over. Thanks.
Thanks. And I would add my comment to Senator Delega with respect to three blokes with Senator Steele-John on the line, and thank you for guiding us through this, because it is an important but sensitive matter that we're dealing with, and making sure that we get the right perspective through the evidence is really important. Senator Steele-John, do you have any questions?
Yes, thanks very much, Chair, and thank you very much for your evidence so far today. I'm interested in knowing more about what you experience either as a service or what you hear from the community directly in terms of the flow through impacts of the service and healthcare deserts that we've heard a bit about today. It's often spoken about in kind of wonkish policy terms, but I'm really interested in the human stories that you encounter and hold in your possession in relation to what this actually means in people's day-to-day lives.
Well, I can tell you from a personal perspective about somebody that I know that has got diabetes, edema, and they want to give her a heart echo, want to give her an MRI, and she's on Centrelink benefits. So for her to investigate those to get the best health outcomes, she has to ask family, and if they can't pay that for her to have that, then she doesn't have it, and it's affected her health dramatically, not being able to get the right diagnosis as a young woman, to be able to, live in a community and feel part of a community that she's contributing to, because her health doesn't allow it. But there's also shame in a way, saying, well, I can't afford it, so how do I just say I can't make it, rather than that there's that shame factor that comes in, because they just can't afford something they really need to do, which is really sad.
Of course. And in terms of actually cost, it's absolutely a barrier, but also just when the wait time is so significant, or you simply can't get that, there isn't a professional in town or a specialist in town that lines up with what you actually need. Are you hearing from people that those things are also very much factors?
Absolutely, and sometimes people have to go to Melbourne from here, and that's not always easy. If you want to rely on the train is not reliable. It can take you 4 hours, it could take you 5 hours, and then that doesn't get to where you want. But it's prohibitive sometimes travelling to Melbourne, or if it's not Melbourne, or it's Canberra, or it's Sydney, but sometimes we're out of the zone. Like in the abortion space, you can't go to some of those places because we're out of the catchment. So then women don't even go down that place because they can't do it, because it's just prohibitive. And so there's lots of layers to it but it comes down to, sometimes they just give up. And they just think, well, what's the point? Nobody trusts me, nobody believes in me. Who am I? That self-worth drops as well, so that they don't even fight in the long run to have those good health outcomes.
Yes, absolutely. Ms. McMillan, would you like to add anything? What your colleagues shared?
Sure. Marge's experience in Albury is reflected in so many of the centres that we talked to about this submission. I remember talking to Wagga about abortion access, and women were going to Queen Vianne in Canberra because that was the closest place that they could come, or into the city. And that comes with additional out-of-pocket costs that makes it very, very expensive. But also the delays for healthcare, they push women onto more expensive options for abortion. So you might be, if it takes more than 9 weeks, you're out of being able to have a medical abortion. You have to have a surgical abortion, and that's going to come with greater costs. So there is really an unfair burden placed on rural, regional, and remote women to access the same healthcare that we have in the city.
Yeah, absolutely. And in terms of the kind of complex interplay of accessing these services, should they exist, but also we heard a little bit earlier in the session concerns around privacy and the need to be able to access telehealth items and things like that to maybe speak with a specialist or a generalist specialist that isn't part of the community for fear of that private information leaking or being perceived to leak. Is that something that has been shared with you as a concern as well around privacy?
And we've had some people, when there's been a referral made to us or from us, they have this perception that their whole story's been shared, which it hasn't been, and then they just back off from a service. And that's happened recently, saying, "You've shared my story." No, we haven't. We've just put you in a place where you knew that referral was going there because they could pick you up. But then that stops them too, because they're scared about who knows what. And particularly if you go into the First Nations community or the coal community, because they don't want people to know their stories particularly as well.
Absolutely. All right. Well, look, thank you so much for your evidence this afternoon. It's been really useful for us to hear it as a committee. And as I said to a previous witness, if you leave the table and often, like I do, go, I wish I'd have shared this or that or the other, you can provide additional evidence to us within the next 2 weeks to include within our report. All right. Thank you very much for your time. I'll pass back to the chair.
Thank you.
Thanks, Senator Steele-John. I just want to go back to the terms of reference and some of the elements there, which through your submissions really blend a lot of the different elements of the terms of reference together. So the issue that we heard about first today really related to the restrictions around the utilisation of the telehealth service, particularly for mental health. But I'm taking from what you're saying, it has much broader implications than that, because it could go into so many other things that would support the referrals that would be needed for that more holistic care that people will need out of some of the events, and graphically demonstrated by the example that you've put in front of us with your supplementary submission. Would that be right?
Yes. You can't just, if I'm understanding what you're saying, you can't just deal with one aspect of that person's journey. Yes, so you might have telehealth for mental health, but there's all those other aspects that come into play, and it's important to be able to cover all of it holistically, which we try to as much as we can where we are, to make sure that they're supported with different services. Is that what you're asking?
Yeah, look, it does, but there would be other service types that would be available via telehealth, which would also facilitate dealing with some of these other issues, or ensuring that as a part of that process, those appropriate referrals finally get made as you work your way through the system.
Yeah, I think with telehealth, well, I'm going to talk from our perspective with the clients that we deal with.
That's exactly what we want you to do. Thank you.
Sometimes it's not safe and secure for them to be in a telehealth position, because you don't know who's going to walk in the room. It might be the perpetrator, it might be your children. So some of that sensitive stuff needs to be face-to-face in a one-on-one space. And because my counsellors do offer telehealth or telephone calls, and sometimes it's, the kids are here, or call me back because it's not safe. So we've got to look at it that way as well. It's not always the answer. There is a local clinic now that does telehealth a lot, and on the weekends, and 10 till midnight, which might suit some of our women to go and have that in a private space, but they've got to know that they're safe to have that conversation at that time, and it's not always safe for them.
So there's a series of underlying things that sit with the group of people, the women that you're supporting,
yes.
That are also absolutely necessary to deliver the appropriate outcomes, or good outcomes.
Yep. And if I think of my mum at 92, she would never have done a healthy telehealth one. She wouldn't know how to do. She knew how to work computers, but she would never have trusted talking about herself into that screen. So there's a whole. I think it's different for different demographics of people too.
Absolutely. And there's a range of things that go through to that. There's the digitally disconnected cohort demographic, if you like, and that brings in a range of things that you've already talked about, called more elderly Australians. They don't feel comfortable with the technology, necessarily trust the technology. Do you actually facilitate the utilisation of telehealth through your service, at your service? So someone could come to your facility and then access a provider?
They can if they need to, yes. Okay. And sometimes for safety, that's what we have to do. Absolutely.
Okay. So can I just run through those, Ms McMillan, on the broader New South Wales sphere? Could you?
Yeah. Well, we definitely had, so from Women's Health Northern Rivers, who had the devastating floods, they said that the restrictions really didn't work for their rural regional context. People couldn't get to their services. And I think also, looking at the cost of living crisis and things like petrol, the more that you can open up telehealth for rural, regional and remote Australians, the better.
So we had recommendations from other providers, particularly focused on mental health, but with respect to having a change around the definition based on the MMM classifications, and they were suggesting 2 to 7, which would cover some of those areas that direct accessibility or locational availability doesn't exist, but it would open it up to them to be able to access those services.
Absolutely. I do note that even though, we looked at one women's health centre who we consider rural, regional and remote because it's in the Blue Mountains and they don't have the same access to service. They're graded as an MM1 location, but they've struggled to attract and hold GPs too. So I guess, I would definitely be opening it from 2 to 7.
Yeah, I'm happy to concede that the MMM system's not perfect, and there's been attempts to massage it at times, but it's very, very difficult.
Possibly in your stress testing, one of the questions is whether women will actually take it up. Yes, they have services in Sydney that they could go to, but through women's health centres, you could actually be asking, do they go to them? If they get a referral to a GP that's 100 kilometres away, or to a referral to a specialist, do they use it? Because I think, to me, that's the question. Are they, we know that we can hand out those referrals, but if women don't take them up, it's not successful.
So you mentioned distance there, which is an obvious barrier.
Yeah.
What would be the other barriers that you would experience?
The cost of getting there, so out-of-pocket costs that are connected to seeing that specialist. I guess trauma-informed care is often a barrier. One of the things that women's health centres do very well is we talk to the services that we refer to. And so when a woman is being referred, we call them up and, we introduce them on the phone and we tell them what the appointment is going to be like and what the waiting room looks like and what will happen in the appointment. And that's one of the ways to make sure that people do connect to care at an unfamiliar service. And we make sure that we talk about cost. This service, they're going to charge you this much when you get there, and you'll get this much back on Medicare. And that's one of the things that Marge pointed out before, that is a real barrier. The having to pay the full price of a service can be a massive barrier to people taking it up.
So I think we might have been talking informally before the hearing started about this in the context of how the private health insurance system works, where you hand over your card, the service takes the rebate, you pay the difference.
The gap, yes.
Yeah. Versus, I wasn't going to use the dreaded gap word. Senator DeLeger might get a bit edgy with me, but that's right. That's effectively what you're talking about. But in terms of Medicare, particularly since the advent of electronic payment systems, it's you pay up front and then have to wait that 24 hours to receive the Medicare rebate back, and so whatever the gap is, but the 24 hours might be not sustainable in terms of your overall finances to actually go through with that process. So would be...
You might not have the money, you might not have the initial payment. If it's a scan, like that's an expensive medical item. So you might have to have $1,000 in your checking account. And if you don't have it, it doesn't matter what the bit that comes back is, you just can't pay for it.
So my question was going to be, making the system cater for that, that would be of benefit.
Yes.
And assistance to the people that you're supporting.
Yes.
Yes.
Okay. I'll leave it to someone else to try and design it, but I just wanted to get that on the record because I thought it was a very salient conversation that we had earlier, and the fact that you're both saying the same thing to me is useful in the terms of the broader conversation.
I hope so. One of my staff members has 2 children with disabilities, and most often children are bulk billed, but the referral to get an MRI or a scan, something recently, was referred by was a private referral, but she didn't know till she went to the place, and they said, no, you'll have to pay all this money now, but if you go back to your GP, get on the wait list, go back to GP and get the GP to refer, then it's bulk billed. So that was just wrong.
So it's coordination and structure of the way the system works in supporting people actually accessing the service. And for those diagnostic things, the upfront out-of-pocket is basically an inhibitor to access of service for the people that you're supporting.
Yes.
Okay. Your submission recommends the removal of the restrictions on telehealth provision. We've covered that a little bit. Is there anything else you'd like to add to that element? I think we've talked about some of the impacts and also the inhibitors to actually utilisation of telehealth, which is an important thing for us to consider. You also talk about expansion of Medicare item numbers for nurse practitioners and midwives. Now, we've had nurse practitioners in here. The Health Minister will be very nervous that we're now talking about midwives. Are there any further consultations that you think should be covered? I mean, they're all important elements of the
I think Jackie probably will have more
system, but
on that.
so I think
just the full range, that not every nurse practitioner consultation can take place in 6 to 20 minutes. Often nurse practitioners are delivering health promotion and helping people manage complex conditions. So they need a few more item numbers that recognise the provision of complex care. That's what they're good at. And I think the centres that talked to in the submission about this were saying it's not possible on those because you can't book your 20-minute appointments 1 because they always run over at women's health centres. So we can't make it sustainable to provide these services on what Medicare is delivering back.
So what I'm interpreting you're saying to me is that nurse practitioners play a very important part in the health delivery system, particularly within the structure of your services, but also which is part of what we're talking about today in regional settings.
Yes. And yes.
Anything you can do to support them having an expanded role and being able to cater to the time needed when people have complex presentations, when they have a lot of intersecting health issues. And as Marge said, the GP saying you've only got 10 minutes, so you can only cover one of the things. Like often, people come in with a shopping list of things that have been going wrong that they've been holding over for a long time. If we want to intervene in people's health we want them not to wait until they have a full shopping list, and we want to get through that shopping list when they come with one.
So it's all very well to expand the scope of practice for nurse practitioners, but you have to make sure that the system actually compensates them for undertaking that scope of practice as a part of the delivery of the broader health system.
Absolutely.
Yep.
Okay. Right. I think I'm done. Do you have anything else, Josh? Thanks. Okay. Look, can I say thank you very much for coming in and talking to us today, and thank you for your submissions. They provide a very stark demonstration of the importance of what you do. So thank you for what you do as well.
Thank you.
In the communities. It's really important. I don't think that you've taken any questions on notice, but if you have, or if, as Senator Steele-John said, you have anything else that you think we need to know, if we could have that by the 7th of May, we appreciate that very much. So thanks very much for your evidence today.
Thank you.
Thank you.
Thank you.
I understand our next witness is online, Dr. Emily Suhrmann. I hope I've pronounced that right, from the School of Public Health at the University of Sydney. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you.
Yes, sir.
So for the Hansard record, could you please state your name and the capacity in which you appear today? They'll then invite you to do an opening statement.
All right, thank you very much. Good afternoon. My name is Emily Suhrmann. I live and work on Wiradjuri country in central New South Wales. I acknowledge the traditional custodians and sharing of knowledge over generations, and am speaking today on behalf of the Sydney School of Public Health at the University of Sydney.
Thank you. So would you like to provide us with an opening statement?
Yes, sir. Thank you. From a public health perspective, the Medicare funding initiatives that seek to improve access to primary health care for rural, regional, and remote communities are welcome. Access to timely and appropriate health care delivered by the right provider and as close to home as possible is fundamental to good health and well-being. We particularly acknowledge the intent of recent Medicare changes to address affordability through increased bulk billing incentives and to recognize multidisciplinary care and telehealth as part of the primary healthcare system. However, our submission emphasizes that improvements in affordability alone will not resolve the access challenges faced by rural and remote Australians. Access must be understood more broadly to include the availability, adequacy, acceptability, and awareness of primary healthcare services. Many communities already struggle with a limited and overstretched health workforce, long wait times, and difficulties recruiting and retaining the practitioners across disciplines. While bulk billing incentives can reduce cost barriers for patients, their effectiveness depends heavily on practice structures, contracting arrangements, and existing cost pressures. Uptake cannot be assumed, and incentives may not be sufficient to cover costs. Inclusion of telehealth within the Medicare changes is an important acknowledgement of its role. Telehealth can help address affordability and availability barriers, but current billing structures do not fully reflect the realities of telehealth service delivery. We also caution that the current Medicare changes will not likely lead to significant improvements in practitioner availability, nor reductions in avoidable hospital presentations. Workforce shortages, part-time work patterns, and recruitment and retention challenges are structural issues that are unlikely to be resolved through billing incentives alone. Finally, we stress the importance of evaluating these reforms. This includes assessing not only service use and impact, but workforce participation, practice viability, and whether patients are genuinely able to access the care they need in a timely fashion from an appropriate provider. In summary, while we support the intent of the Medicare changes, improving access to primary healthcare in rural, regional, and remote communities requires aligned reform across funding, workforce, and service delivery systems. Medicare initiatives are a necessary component of this reform agenda, but they must be supported by broader place-based and multidisciplinary workforce-focused strategies to achieve sustained improvements in access to quality and appropriate primary health care. Thank you.
Senator Steele-John.
I'm sorry?
No, I was just going to Senator Steele-John for questions.
Oh.
Right. Senator DeLuga.
No worries. Thanks very much, and thanks for your submission. Just a couple of questions about the government's investments into Medicare and the bulk billing by increasing the rebates. What are your reflections about the increases to bulk billing, increasing to the rebates, and the introduction of the Medicare bulk billing clinics, and what effect are they having on the in communities?
Okay. The increase of benefits through the Medicare bulk billing activity is valuable. However, its uptake seems to be limited and informed by practice engagement with the Medicare bulk billing system generally. So while there are some services and practices that routinely provide bulk billing incentives, a number of the practices in the Central West don't, for various reasons. Some of them challenges with the system, tax incentives, etc. And so there's a multi-pronged impact to allowing these incentives to provide the benefits to the residents.
When you say tax incentives, can you expand on that for me?
Yes, sir. In my communication with some of the general practitioners in the area, part of the challenge is navigating the system, and practice managers tend to be responsible for ensuring the bulk billing practices are correct and appropriate in relation to the tax requirements. And so the financial incentives aren't always as payroll tax requirements. And so those incentives can be hard to manage and navigate individually, and staying on top of all of that is an additional challenge that has been expressed.
Okay, so with all the GPs have had an increase in their rebate, and we've seen in this area alone around the greater outside of Albury, Wodonga, that there's been 47% of practices are now bulk billing, and that's gone up considerably over since the incentives have been tripled. Can you do you see that do you acknowledge there's growth in that sector and that GPs are taking it up?
So I'm going to be honest and say I'm not across the data about uptake of the bulk billing incentives. So I prefer to have a closer look at that data to express it, to answer that question.
No, fair enough. And I wanted just to hear your thoughts on the recent Medicare mental health check-in and the expansion of 1-800 Medicare. What are your thoughts on how these will improve services for regional areas?
Okay, thank you. I think the opportunity to employ telehealth services into the delivery of care for rural and remote, really for any region, is valuable. Mental health is an arena and a discipline that has embraced opportunity for telehealth services over many decades. So at one level, it's not surprising to me that this incentive would be embraced and would work well in mental health care and response. Yeah.
All right, thank you. Thank you, Chair.
Mm-hmm.
Thank you. I just want to go back to the point that you were making around the interaction of tax issues, and you mentioned payroll tax. So the government, as Senator DeLeague has indicated, made significant increases into the incentive, but your evidence is that it's not just the money that makes a difference. And you mentioned specifically practice structure, and then the interaction of things like payroll tax with the way that the systems operate. Is there anything in your research would need to be, or what does your research show that would need to be done to mitigate some of those practice structure issues? How do you change that? I mean, it's a private business model, small businesses. It's scary to see the state tax system interacting with the federal health delivery system, but you know, it doesn't surprise me. But it's a huge investment on behalf of the Commonwealth. How do we make sure that we get the appropriate bang for our buck out of this?
Yes, sir. So there's more for me to investigate in this. I'm not across all of the detail at this point in time. I apologise, but my understanding is that it's not just the money alone, as you say. Part of this is how GP surgeries are structured and work, and a lot of them out here deal with contracting clinicians. And my understanding is that if one clinician in the service, in the surgery, is not interested in being a bulk billing practitioner, the surgery cannot be a bulk billing surgery. And so I'm not certain yet what the incentives would be to encourage practitioners to become bulk billing providers. I know when I lived in Broken Hill, every practice was a bulk billing practice. When I moved to Central West of New South Wales, very few are bulk billing practices. And I'm not certain the logic or reason behind them as yet.
Does the requirement or need or presence on high rotation of employment practices like utilisation of locums have an impact?
It might, I think, but I mean, the reality when I lived in the Far West, I never had the same GP from one year to the next. The challenge is rearing its head in the Central West as well, where before there was a fairly more stable workforce. So I'm not certain if the effect of locums would increase the opportunity for bulk billing as opposed to residential clinicians.
I mean, your point about if a GP elects not to be a bulk billing GP, then the practice can't be a bulk billing practice stands to reason, because you've got a GP who's working there who's not bulk billing, therefore the practice is no longer a fully bulk billing practice. I mean, that's just as it is, effectively, because of the way that that particular GP chooses to practice.
Yes, sir.
And it would depend, I suppose, then on the practice deciding whether or not they would want that a non-bulk billing GP working at the practice to maintain the status that they have as a bulk billing practice. I mean, so it becomes more complicated on a business perspective. I'm interested in discussing the point that you make around multidisciplinary practices,
Yes, sir.
and how they may be effective in regional areas where you have a number of disciplines who are working together in an attempt to create a critical mass, if you like, which then generates viability. Have you got any work on that and how the system might need to be tweaked or operate to support that? It's a conversation I've had on a lot of occasions, particularly
I imagine.
in regional parts of the country, including in my home state of Tassie.
Yes.
And with the concept of bringing service, but also viability to a business model, which might not be there for a single discipline.
Yes, I think the opportunity for multidisciplinary care within a practice expands that availability of services. I mean, a parallel example is the services in schools that are happening, where we're trying to bring primary care into a school system in order to ensure access in a different way through the LHD, so private-public activity. However, the interaction of the multidisciplinary team and what can then be available is where that critical hinge sits. But there again, the trick is the recruitment of the providers into a region. The engagement with telehealth services has the potential to expand opportunity and engagement with multidisciplinary services, as long as you have a critical mass on the ground to support then that telehealth infrastructure and integration of not FIFO, but telehealth in and out services, if that makes sense.
There's been a fair bit of evidence today that the November 25 changes to delivery requirements for telehealth has actually restricted delivery capacity and reality in the regions. Do you have a view on that, and what do you think needs to be changed to ensure that delivery is available but also provides the appropriate service that we've discussed on a few occasions as well?
Yes, sir. The impact of the Medicare changes on the opportunity for telehealth, I don't feel I can speak as closely to. However, I am involved in a number of digital health evaluation programs at the moment, and the challenges that we see in that space is an anticipation from external parties that it's a simple matter of just plugging in a system and telehealth will work, when it's more complex than that. And so I think enabling telehealth within this Medicare structure is encouraging, and it is something that should continue to be explored. But clearly it's complex. It's not going to be as straightforward as saying telehealth services are meet this particular item number, because certain communities may not have the necessary equipment. There may not be someone on the ground to support the telehealth connection, to support the patient. We're finding a lot of people, the patients and the practitioners, are encouraged by positive experiences of telehealth care. Practitioners seem to really enjoy the opportunity to attain immediate support for their patient, and that's the piece that patients really appreciate as well, is the immediacy of telehealth support and care without having to travel or wait. However, the challenges surrounding connectivity and viability of and availability of the appropriate people is one of the challenges that we're seeing in the research that I'm a part of. I hope that helped to answer your query.
No, that provides, I think, a valuable context. So what you're saying in that sense is that just as in an underlying sense workforce is a capacity constraint in regional health, which drives a lot of the things that we're talking about, that capacity constraint from a number of different perspectives, connectivity, availability of infrastructure, and also availability of suitable workforce is also a constraint within the telehealth sector as well.
Yes, sir.
Yeah, okay. Just going to a question that I have written down here and trying to align it with what we've just been through. Is there anything in your research that supports practitioner availability? I mean, are there any key messages coming through? And I've had a lot of these conversations too in various contexts, you know, around the development of rural clinical schools and GP who is training people here locally and utilising all of that experience side of the attainment of qualifications as a part of ensuring or maintaining or encouraging availability, particularly into regional areas. Is there any other messaging in your research that could add to particularly that experiential element of the training process?
Yes, sir. Thank you. The opportunity, a lot of the research will tell you the value of rural origin students. True. But I think one piece that's missing is the greater strength of the rural experience. We know that exposure and opportunity to experience a rural placement has a great impact on a student's choice then about where they practice. So enabling rural placement experiences for our metropolitan students is just as important and valuable as it is for our rural students. It's a larger body of people at one level to influence and inform. The detail about what a placement looks like, how long an effective placement can be, the opportunities for placement locations, those are details and elements that need a bit more nutting out. You know, some disciplines have more opportunity for longer term placements. Some provide a frequency of shorter placements that all experiences have a compounding effect. I think one of the other variables in thinking about impact and outcome of such placements is time. So we know that, well, I have seen rural students who come into the rural school, then go into a metropolitan experience and life to establish themselves, but they come back rural in maybe 5 years or 10 years or some period of time. They come back. The rural exposure, it isn't necessarily about immediate placement and life in a rural or remote community. And with some of our students, we've had students come out who enjoy their experience, but for them, they've expressed, this has taught me that a rural and remote life isn't for me, and have said that what they walk away from, though, is now a recognition of where their rural and remote patients are coming from when they need to come to the city for care. And they understand why discharging someone on a weekend may not be the best choice, or how to consider their lifestyle and what's happening in their world, in their care provision, and what's possible. And so their view and experience of caring for patients has shifted. And so I'm a proponent for everybody having a rural experience, but I know we don't have that many rural placements available. So one thing might be how to explore enabling more rural sites and placements to support that experience, which could shift someone's understanding and choices.
So you've almost gone where I was going to go myself, which is the capacity of the rural system, the regional system, to actually facilitate that experience. So that in itself is also a limitation.
Another capacity challenge.
Yeah, okay.
Yeah.
Right. Are you there, Senator?
Yes, indeed.
Still, John?
Yes,
you are.
Yes, indeed. Thanks, Chair. Thank you very much, Doctor, for your evidence to the committee today. I just want to give you an opportunity to focus in on or to expand on what you know from your research in this area around what government policy needs to change to ensure that those who practice in or are incentivized to practice in rural and regional and remote communities actually stay within those communities rather than go for an initial time and then move back to the metro. Previously, we've heard both, I think, from this inquiry and certainly previous inquiries that I've been part of, that policy approaches have been too narrowly focused on immediate financial incentive to make the move, and not taking enough of account of the actual factors that then may motivate somebody to stay in terms of the broader services that are available. One witness summarised it to me as basically reminding us as MPs that GPs in this circumstance are people and live in the community more broadly. They don't just kind of live in the surgery and then in the place that they might be subsidised to live in while they're there. So, any thoughts on that would be very much valued.
Yes, sir. Thank you for the question. And it's a long researched question about retention of our clinicians and practitioners, and a message that holds strong across the research that has been conducted to date is the reality that, as you say, these are people who are living in a community. They're not just there as a doctor. And so you have spouses who will be looking for employment or needing employment, children who need schooling, extracurricular interests. So if someone is interested in music or sport or the like, what are the opportunities within a community for such expressions? The things that, public transport and other elements of what makes a community a space that you would choose to stay and live. When we would have students or new residents to town when I was living in the far west, something that we often reflected with was that no matter where you are, your enjoyment of the place will be what you make it. So you can live in metropolitan city and be happy or not, be engaged or not, and you can live in the middle of nowhere and be engaged and happy or not, as you will. But I think the opportunity, again, reflecting back on that opportunity for exposure. As a rural resident, I'm a proponent of the lifestyle opportunities that a small town offers. I don't understand how people choose to live in the city. And so I'm biased in that sense. But when I talk to people, it's about helping them to express or explore what the place can provide to them, not just what they can provide to the place, because it is a two-way relationship, particularly in rural and remote places. It has to be a two-way relationship. So in thinking about retention, how do you keep people to stay there? I'm going to be possibly unhelpful and say that it's multi-pronged. There's a lot of variables to this, and people who come as single clinicians, it might be about whether they can find a relationship or not. For clinicians who are newly married, it might be about what options there are in building that life as a couple or the future as a family, and understand. And so it's not just the health service, but it's the education system, it's the professional system, it's the services that surround. And as clinicians themselves, they too need to be able to access services and supports. So yeah, again, it's that complex but real relationship. I hope that answered your question.
It most certainly does, and it. I think there's a challenge in there for us all to recommend policy solutions that are as flexible and nuanced as what you're describing there, because I know that often, it's hard to cut a ribbon on some of the things you're describing there, but
yes, sir.
Nevertheless vital from what you've shared with us today. Thank you very much for your evidence, Doctor. I do appreciate it, and I'll pass back to the chair.
Thanks, Senator Steele-John. Thanks, Dr. Solomon. I don't think that you've been asked to give any answers to questions or taken any questions on notice, but if you have, or if there's any further information that you'd like to provide to the committee, if we could have that by Thursday, the 7th of May, that would be appreciated. That concludes today's hearing. Can I thank everybody for their evidence today? Thank you to the witnesses. Thank you to Hansard and Broadcasting. It's good to have the video system operating here in regional Australia. That's a piece of good news. Thank you to the Secretariat. The committee stands adjourned.